Hello and welcome to the BloodStream podcast, a show serving the greater bleeding disorders community, brought to you by Believe Limited and BloodStream Media, and made possible thanks to our presenting sponsor, Takeda. I'm your patient advocate and host, Patrick James Lynch.
And I am your healthcare advocate, nonprofit nerd, and your other host, Amy Board, reminding you to please speak with a healthcare professional before making any treatment decisions.
On today's show, Jess Swann and Dr. Ben Kim from Star Therapeutics join us to talk all about Star Therapeutics, their commitment to the von Willebrand disease population, and much more. We've got that coming up and more on today's BloodStream. What am I trying to say, Amy?
The next one and today.
Okay, it's a 5-part series in which we've got that and more.
Literally.
On this episode. Welcome to BloodStream.
Listeners, as always, thank you for joining us today. Thank you for staying with us today as we, do our thing. All the things. If you like what you hear, please share this episode with your family, with your friends, all the things. Please share it on social media even. Let's get more people into our BloodStream media community. We love that. All the things.
Heck yeah, here, Amy Board 2026. I also want to remind you, dear listeners, that the BloodStream podcast is made possible thanks to our presenting sponsor, Takeda. Yes, that's right, Takeda. Takeda's got this website, bleedingdisorders.com, where you can learn all about Takeda's resources for and commitment to the bleeding disorders community. Takeda, Amy, believes in a world free of bleeds.
What a vibe.
Quite the vibe indeed, and they are dedicated more than ever in their efforts to offer a wide range of programs and support for patients on that treatment journey, wherever on that journey they may be. And you can learn more by simply visiting bleedingdisorders.com. One more time, because doubtful you've heard it yet, bleedingdisorders.com. And for their founding and ongoing support of the BloodStream podcast, I would just like to say thanks, Takeda.
Thanks, Takeda.
We are recording for the second time in a row, Amy, from our respective homes as we are in the process of moving. So neither of us are in studio today, but that should be different by the time we're recording for the next episode, I believe.
I think y'all are going to get like a new studio vibe at some point, some future episode. Again, I don't pay attention to when it's supposed to be complete, but it's going to, like, they're redesigning our podcast studio.
They are. That's pretty exciting. We looked at pictures. We made suggestions about the designs and the layouts. It was very official.
I asked if I could get like a picture of Taylor Swift, like, to my left, just as like a little angel on my shoulder. I don't think I'm going to get it. Keith didn't look psyched.
Interesting. Not in the budget?
Yeah. It wasn't in the budget and like not in the aesthetic, whatever.
Well, I'm not going to come between you and anything T-Swift. So if you choose to go hard for this, just let me know. And I will do my best Homer Simpson backing into the bush to let y'all have an opinion on what color the couch should be. I'm like, what?
Oh my God. When Rob and Ryan have an opinion on anything, just Patrick and I just slowly go to the back. Both of us just mute, and you can just see us scrolling on our phones, just waiting.
The dust will settle. The storm will calm down.
One opinion will win. We don't take sides.
It's basically a battle to the death, and it's like, who won that round? That person? Cool. That's what we're doing? Good. Fine.
Great. Sounds great.
We haven't taken a beat on the podcast since we've been back from Colorado to touch on anything BDC related.
Yeah.
And I know we're now a few weeks out, but I thought it might be nice, Amy, to just kind of say a word or two about one of your highlights from this year's BDC.
Oh, that's lovely. I can't believe we didn't do that last episode. I guess there was so much we had to chat about. My highlight, and I'm sure this is on your list too, if not your highlight as well, was the premiere of Dismissed, our film Dismissed, that featured a handful of women who have hemophilia in the community. I think it was one of the most powerful end of film discussions that we have had. A lot of times after our films, the discussion is kind of about the characters per se. It's about the movie making in some way. And this film really transcended all of that, and it was truly issue based, and the dialogue was so passionate and I think heated, but not there wasn't it wasn't, no one blamed anybody. There wasn't I don't put words into my, what am I saying, Patrick? It wasn't
It was passionate, and
combative.
no, it
It
wasn't
wasn't
combative at
combative.
all. Mm-mm.
Yeah.
No, but there were some really strongly worded
Yes.
urges for support. Women asking doctors and people of influence in the room to use their platforms, men asking other men in the room to step up and be better allies. So there were strongly worded messages, but nothing that was combative or unproductive. It was all extremely productive, and I agree. I think it was one of the most, um, for lack of a better word, satisfying
Yeah.
talkbacks, Q&As that we've ever had after a film. And I've reflected on something that our team member Kay said when asked about watching the film in real time with the audience. Kay was on set as a camera operator, but more notably was co-writer and editor of the film. And spoiler alert, but there's a young woman in the film who has a self-infusion journey. And when the moment in the film came where she does, in fact, for the first time, self infuse without a nurse or medical professional present, the audience broke out into applause. And Kay cited that moment as a storyteller. And I don't remember exactly what she said, but my takeaway was like, that was everything. That kind of
Yeah.
said it all in some way. And I've thought about that night sort of that way, that how that room responded to the whole film throughout the talk back was just, it was just so right and felt
Yeah.
so appropriate. I will say, and I appreciate this, there have been some who have said, okay, this movie's been made. Now what? So what? What do we do about it? And I think that's a great question to ask. And I think it's great that the film can be teed up and platformed in such a way that it encourages people to ask that question, because that's exactly the right question. What do we do now? What can I as an individual do next at a very local level for my family, for the woman with a bleeding disorder in my life? I think that's exactly the right question. So if you find yourself asking that, that's exactly the right question. And I'd say start with your own backyard. Get involved in your own local community, your own local advocacy efforts, and tell other people about the film. Make more people aware. A lot of this starts with awareness. Doctors are not aware. Lawmakers are not aware. There's this antiquated idea that still holds quite a lot of water in our community, that women can't have hemophilia, that women don't experience bleeding disorder symptoms like men do. And we need to do whatever we can to use this film and the stories therein to dispel that idea. Ideally once and for all, right? Ideally.
Right. I really, I, since we're our guests later on today's show are um, in the vWD space, and so I just wanted to mention our larger community of those that feel disparity of care here, in terms of treatment and just access to care. Our vWD community. This film was funded by a grant specifically about women with hemophilia, and so that's really what the lens was. But I just want to extend the issue, to extend the storytelling, to extend the challenges that all women face in getting access to treatment, adequate treatment, being part of clinical trials. It is just such a long road that we have to go to really make our care equitable for our women in the community, and our women's particular bleeding symptoms, just so different. And we've never studied it. We've never studied it in women with hemophilia and in von Willebrand. So I just want to extend it to all of our community. And just like you were saying about like, what do we do next? I also want to couple that with women who have maybe thought about their symptoms or really pushed their symptoms to the back burner, that this might this film might give you the courage to speak up, to find a physician that listens to you, to change physicians, to really put your voice in front, instead of having it maybe be shadowed behind your children or behind your busy schedule or behind maybe even some shame and fear that you won't be listened to. But it was really moving, the premiere, and I have to shout out our colleague, my very good friend Don Rodolini, who was selected to be a part of this film as a cast member to really be our spine. You know, she's so eloquent in terms of what the issue is, and she's so passionate and she's so well spoken, and we knew she had a personal story to it. I've always known, throughout my friendship with Dawn, now over 15 years or so, knew that she was a carrier of hemophilia. Of course, her son Gino has mild hemophilia. But to hear her story, that when we were filming her interview, was a bit of a surprise as well. We knew we would ask about it, but I think it was a surprise to her, and it was a surprise to us about how, I'm like getting goosebumps of how emotional it was, how raw it was, how authentic her experience was, how she could articulate it. And she told me later, she was like, I've never articulated it like that. You know, it was just like this, just magic, just captured. And to watch the audience there respond to that, to watch her be able to stand up in front of her colleagues, and she is at the top echelon of some very significant folks in hemophilia that move the needle, to have them hear her story, which they've never heard, was so powerful. And I just a small hats off to my good friend Don Rodolini.
Well, and listeners, you can watch Dismissed for free by going to dismissedfilm.com. Click watch the film on the homepage. There's a very short little form you got to fill out to get access to the unlisted link, and you can watch it for free. It's about 40 minutes long. And please, if you do watch it, if you have any comments, anything you'd like to share with us, feel free to reach out to either Amy or I on social media or to BloodStream Media. We would love to hear from you. Well, two people that were in the room for that BDC premiere of Dismissed are Jess Swann and Dr. Ben Kim, each of which who had interesting comments. I don't think they mind my sharing just before we go to the interview. You know, we had tried to record with Dr. Ben and Jess some weeks prior and had technical issues. And Ben had said, you know, I'm actually glad it worked out this way. I'm glad I got to see this film first. And I don't know if anything necessarily that he shared in the interview was directly impacted by his watching the film, but I just thought as an experience that he had, something about ingesting that film led him to think, I'm glad I watched this before I came on the podcast to talk with them. I thought that was interesting. And to your point, Amy, about the focus of Dismissed strategically for reasons was on women with hemophilia, Jess had made the point, you could swap out hemophilia for von Willebrand disease and basically do the exact same thing, because the women there are also being dismissed, being ignored, being underappreciated, underdiagnosed, not involved in clinical trials, and so on and so forth. And I appreciated that she brought that insight as well. So let's hear what other insights they have to bring. This is Jess Swann and Dr. Benjamin Kim from Star Therapeutics. All right, BloodStream listeners, I'm joined now by Ben Kim and Jess Swann of Star Therapeutics. Ben and Jess, thank you so much for joining me today here on BloodStream.
Thank you. Glad to be here.
It's our pleasure. Thank you.
So we had the chance to see each other a couple of weeks ago at the BDC in Aurora, Colorado. And Ben, we had a chance to meet just following the screening of Dismissed. Jess, we spoke then as well and have known each other for many years. There's a number of places we could start, but I suppose let's start with what Star Therapeutics is, because it's a name that in the bleeding disorder space we hadn't heard, and then we started hearing about. We're hearing about more and more. So let's start. Maybe, Ben, you could take this. What is Star Therapeutics?
Yeah, Star Therapeutics, we're a private biotech company based in the San Francisco Bay Area, and we have been on this mission ever since our inception in 2018 to transform lives of patients with serious diseases by discovering and developing best-in-class antibody therapies. And our scientific leadership had previously developed a first-ever antibody treatment for a rare blood disorder called cold agglutinin disease. So they were very familiar with developing drugs for overlooked and underaddressed hematologic conditions. And myself, having been part of the bleeding disorder community, first as a HTC provider at UCSF, and now for over the past 10 years, leading clinical trials of novel treatments for hemophilia primarily, it was really clear that people with vWD, substantial proportion of whom are women, girls, and persons who have the potential to menstruate, didn't have the same level of innovation afforded to them. And so we thought at Star, how could we think outside the box and develop a treatment that could potentially treat multiple bleeding disorders, but really focusing our initial efforts on vWD, a population that's not seen much in the way of innovation for really decades. And can we marry the science with patients' unmet medical need and take on this challenge? Because there's been other companies that have maybe thought about this, but have not been able to bring something that could really treat the entire vWD population. So we went through a lot of deliberation, collaborating between the clinical scientists, the people who are overseeing the clinical trials, as well as the researchers, to think about how could we do this. And we landed upon trying to target a protein in the blood that's called protein S. And by doing so, we have developed this monoclonal antibody, a therapeutic antibody that targets protein S, and by doing so, works to restore the body's natural ability to form blood clots. And because it's an antibody treatment, it could be given as an injection. And because it has a long-lasting effect in the body, it could be dosed very infrequently in terms of multiple weeks between injections. And so sort of in a world when I took your initial question and sort of expanded, but we are really hyper-focused on trying to meet unmet medical needs and trying to use our brains in an innovative, novel way to be able to do that. And the magic happens when scientists and people who are really closely sensitive to the patient community come together and it works out.
And you did a nice job of giving us your background there. In addition to the specifics about Star, I should just mention you are the Vice President of Clinical Development. So when talking about the clinical trial programs, Ben's the guy to speak to about that. Jess, you've had a number of roles within the bleeding disorder space over the course of your career. What is your role now at Star, and why did you find yourself there? What attracted you to Star?
Yeah, well, thanks, Patrick. You're right. It has been quite a journey. I started in advocacy as the executive director of the Hemophilia Association of San Diego in 1998. I'm dating myself a little bit here. That was an interesting time for the community because it was in the middle of the HIV and AIDS crisis, and I was supporting families through funerals as I was getting to know them. But one thing that really impressed me just then and continues to impress me now is the resilience of these families, right? That continue to endure so much. So starting off in that space, I remember telling Glenn Pierce, who was a community member in San Diego, a pretty storied physician in the hemophilia and bleeding disorders community too, that I was going to be moving to a new role. And he said, "What? We can't leave hemophilia. We've taught you too much." And I remember saying, "Well, what else could I do?" It was clear that the Hemophilia Association of San Diego was in good hands. They were kind of looking to take a little break from and adding any more programs or services. And he said, "Well, what would occur in biotech?" And I thought, biotech? What can I do in biotech? Well, it turns out there's quite a bit that I could do in biotech, having had the privilege of working across a number of great companies, launching a string of successively more innovative treatments, including leading company marketing for Alprolix and Alactate, being the global commercial lead for Hemlibra, being the BU head for Roctavian before moving into a corporate strategy role. But at Star now, I am the vice president of global commercial strategy for our bleeding disorders program. And when I learned what Star was doing, I was just excited by the mission. And I was particularly interested in the fact that they had chosen to focus and start on vWD. As we all know, vWD is the most common bleeding disorder, but it also impacted a dear friend and mentor of mine in my early years, Renee Paper, who had vWD and was a huge inspiration to me and so many others in this space. So I do think of this next phase of my career as kind of dedicated both to Renee and her memory and her legacy, and also to so many incredible people with vWD who continue to triumph day after day, despite a lack of really novel treatments like the hemophilia community has seen in recent years.
Yeah, and to that point, what have you experienced from a von Willebrand disease perspective over the course of your career since starting in '98 in that advocacy role? Can you talk about the progress or development or lack thereof that you've seen for the vWD community over the course of your career?
Yeah, I remember early on doing a lot of education with Renee Paper, where we would educate school nurses and really were trying to help support enhanced and earlier diagnosis, since people with vWD generally are diagnosed in their teen years, unlike hemophilia, where you have that diagnosis generally happening within the first year of life. And fortunately, there are treatments for this space, but when you compare the numbers of treatments, I think there's about 6 treatments for vWD compared to almost 40 treatments between hemophilia A and hemophilia B, and successive innovations in the hemophilia space, despite vWD being a much larger population. So I think it's high time for innovation in this space. And, Ben and I have had the privilege of bringing innovations to the hemophilia side. And I think what really excites us is the opportunity to do something similar, hopefully for vWD patients.
So Ben, to that point, Jess mentioned there's 6 treatments available for patients with von Willebrand disease, which is obviously nowhere near 40, but it's also not 0. What is it that makes the 6 available treatments for VWD insufficient?
Yeah, that's a great question. I think it's due to a number of different reasons. So as Jess mentioned, the patients who have VWD oftentimes get delayed later, and there isn't the kind of really drilling into patients' minds that you need to learn how to self-infuse and you need to be able to do it, and it has to be, you need to be on prophylaxis to prevent serious disease burden and morbidity. And I think that the mainstay of treatment options for VWD patients directly treating the disease has been factor concentrate. And I think one of the perceptions or misperceptions has been that the factor concentrate therapies they work for hemophilia boys and men. They should work for VWD women and girls, and it just hasn't panned out that way. I think there's challenges with regards to infusing, from a venous access perspective, but also just the overall challenges of doing this on a continuous basis. The other thing is that there are treatments that have been used as adjunctive therapies or treatments that help with some of the manifestations or symptoms of the disease. These include things like tranexamic acid, DDAVP, and nasal formulation, and hormonal therapies for menorrhagia, and these are options, but they're not really addressing the underlying issues with regards to the problems that VWD patients have with forming stable platelet plugs as well as stable clots. And so I think that because VWF, von Willebrand factor, the gene for that is so big and has so many different mutations, patients with VWD are divided up into 3 different types that have different issues with their VWF protein. It's a lot more complicated than hemophilia A or B, where it's a coagulation factor, and it's got, usually one job to do. It's be helping to form that stable clot. It's made things challenging, and from a therapeutic perspective, the only way that we've been able to do this has been to replace with VWF factor concentrate, and IV 2-3 times a week has just not panned out to be a really effective option. And so, we're thinking, are there ways to be able to improve the way we administer the drug subcutaneously, in this case for VJ039? And is there a way to reduce the frequency of the bleeding burden? At the same time, we've been trying to think about, are there ways to be able to just really improve the ability for the body to form blood clots? So we call this restoring hemostasis. And can we do this even better than some of the other treatments that are out there? We've set a high bar to try to meet all three of those. And I think by achieving those, this all needs to be, played out in clinical trials. But that would be something that could really transform the treatment experience for patients with vWD.
I want to follow up on the mechanism of action. You used a word in there earlier, antibody, which can be a little scary to hear. Antibody, I think about inhibitor development as someone with hemophilia, from that bias anyway. But can you tell us a little more? How are antibodies used therapeutically? How is that not something scary, Ben?
Yeah. So antibodies, they in the body itself are usually designed to help clear out things or bind to things. And they've got unique properties because if you form an antibody in your body, it lasts for a long time. Now, in the context of an inhibitor, that's not a good thing because it clears out whatever factor VIII you get. But in the lab, what we can do is engineer these antibodies to have specific properties. So, for example, our antibody is not designed to clear out, whatever it binds to, protein S in this case. Our antibody is not designed to increase inflammation to cause some other problems potentially. And so by using technology to engineer these antibodies to only do things that we want the antibody to do, and then also have extreme specificity, meaning that it's only going to do this one action that we design it to do, these can be used in and take advantage of the good properties of antibodies, meaning that they can last for a long time, they could serve a specific purpose, and they're not going to, ideally be binding to other things that we call cross-react with other proteins in the body, and try to, maximize the good and minimize anything bad related to it.
Well, that makes good sense. I want to switch gears a little bit, Jess, and ask you about the medium to long-term vision of STAR, because while we're focusing our conversation and the focus of STAR is on von Willebrand disease, in the messaging as I explore your website, there is talk about other underserved bleeding disorders. What are some of the other populations of interest to STAR in the long term?
Yeah, well, I think as we think about the mechanism of action that Ben was talking about, there is potential for this to be a universal hemostatic therapy and the first subcutaneous therapy for IBD prophylaxis, which could be quite transformative. I think that's something we'll be looking at in the future. Certainly, we've started with vWD, where we believe the unmet need is the highest. But as we think about other areas, think about different factor deficiencies that could be quite rare, but have even fewer treatment options for those small populations. Those are definitely areas that we'll be looking at in the future.
How do you know the unmet need is so high in von Willebrand disease, and what does that unmet need look like? What does the burden look like?
Yeah, well, and Ben has already talked a little bit about some of the limitations from a treatment perspective, but it's not uncommon for us to hear stories of people missing significant amounts of school or work due to bleeding and treatments requiring frequent infusions. A lot of times severe bleeding leads to anemia, potentially to blood transfusions. Kind of the impact of iron deficiency and anemia can be very significant. Thinking about cognitive impairment, lack of energy, ability to kind of carry on daily activities. The other thing that I think is really unique is as we think about this delayed diagnosis, what happens over time is that people normalize the bleeding that they're experiencing, whether it be for familial reasons, such as, Mom, my period is very heavy. I'm going through a lot of tampons. Well, that's just how our family bleeds. That's how I bleed. That's how grandma bled. Kind of rationalizing it for those purposes. Or sometimes it's just through the medical system where they're not believed or their symptoms are dismissed, where they're told you just bruise easy, so put on a sweater and cover them up. Or, their pain is dismissed through different bleeds, or they're told you can't possibly have a joint or muscle bleed because you have vWD, because you're a girl, for example. Things like that, these kind of misconceptions that happen over time, I think both contribute to an amazing sense of resilience that we see in people with vWD, as well as a normalization of pain, of bleeding, of bruising, of things that they start to think are normal. And by the time they do get to a diagnosis, oftentimes it's later in life, either after childbirth, and they just determine that their own child has a bleeding disorder, and they do too, or through some type of traumatic injury or accident that gets them in trouble and they suddenly have a diagnosis. So they've normalized this whole world of kind of bleeding being normal, and don't even realize that things like bleeding in your gums for 10 or 15 minutes after you brush your teeth isn't normal, that multiple nosebleeds, lasting more than 15 minutes and happening, frequently are not normal. But they may feel normal for someone who's had their symptoms dismissed and been told this is normal throughout their whole life. And so it's a very interesting dynamic here where there's this massive tolerance of a lot of the symptoms that are happening, underreporting, lack of discussion with physicians around some of these things, because even after diagnosis, that's still a part of someone's baseline. And so I think we have a real opportunity here too to help reset the conversations between physicians and their patients beyond just the diagnosis, helping reset what normal looks like, both from what does normal menstruation look like? What does normal nose bleeding look like? What does frequency of bruising and sizes of bruising and other things entail? What do you really have to endure? And that, reopening that dialogue beyond the initial diagnosis and the diagnostic instruments that we have that help people get diagnosed, I think will be incredibly helpful. And when we have seen this happen, the trust that's built between the physician and their patients and the ability to avail themselves even of currently available treatments has definitely resulted in improved quality of life for patients I've talked to.
Wow, there's so much in what you just said. Thank you for walking through that. I suppose I want to take that, Ben, to a question for you about the program itself, because there's two data points that always stand out to me when talking about vWD, thinking about vWD. The fact that as many as 1% of the population may have some form of von Willebrand disease, that's a lot of people. But that up to 90% of those people are undiagnosed. That gap seems extraordinary to me. How have you found the recruitment for the clinical trial and the patient response to Jess's point about the massive tolerance and the normalization of the abnormal? Has it been difficult to find patients to step forward and participate in the trial? Have patients been eager? What's that been like?
Yeah, those are great questions that you just asked in that one question. I think that the main thing is that vWD manifests, meaning that patients experience this as prolonged bleeding. And it's usually of visible areas, so like the nose, the gums. So people who don't have a bleeding disorder can have nose bleeding and gum bleeding. And, certainly women can have menstrual cycles that may be a little bit longer than what is average, and they don't have a bleeding disorder. I think that because this is prolonged bleeding and not abnormal bleeding. So hemophilia patients, it's abnormal for you to have spontaneous joint bleeds or huge muscle hematomas. And so when you see that, it's like, oh, this is really off. But when you see prolonged bleeding, it's like, well, it could be due to a number of different things. It's not just going to be, pointing me to vWD. It could be, just you've got a blood vessel in your nose that's just a little bit too close to the surface and it gets irritated. So I think that's part of it. In terms of, kind of thinking about what the things we're trying to do for these patients who are looking for treatment options and trying to ideally recruit them to our studies, we've tried to make it very clear with regards to the criteria for our trials. So we're looking for vWD patients that have symptomatic bleeding, and we've been centering our efforts at HDCs that have known populations of von Willebrand disease patients, and so oftentimes it's the severest of the patients, of the severe vWD patients, that will raise their hands first because, not only are they having prolonged bleeding, but sometimes if you have type 3 vWD, you could have joint bleeds, or, even with type 2 or type 1, you could have more significant bleeding, including joint and muscle bleeds. So these are the patients, because we go to the HTCs, there's a known, albeit a relatively small group of people that have been interested. But I think as we're getting more and more out into the community, having discussions with advocacy groups, chapters locally, and explaining that we're investigating a treatment for vWD, I think patients who are maybe not as well tuned into their HTC and the IV factor concentrate prophylaxis treatment options, they're starting to raise their heads and say, maybe this is something I should listen to because I haven't heard about new treatment options. And I think that slowly the word is starting to spread. It's not just us. There's other companies in the space, and it's great because vWD patients need to have more options, and by having more options, they become more engaged. We're finding that the characteristics of what we're trying to develop are different enough, and quite a bit different, I would say, compared to what's currently available, that we're getting at least an initial interest and audience from a lot of people. The only way to really continue to enroll patients at a good clip is to just be trying to speak with investigators, hematologists, patient advocacy groups, folks like yourself, to kind of get the word out about this and start the dialogue. So, when vWD patients go for their comprehensive visit each year, maybe it's a good time to ask what treatment options are there that are out there. It's maybe not a topic that's been raised before, like in hemophilia patients' comp visits. They're oftentimes like, hey, tell me the latest and greatest. I think it's high time for vWD patients to maybe start asking as well, and just getting awareness, access improved and increased. I think could really start to change the experience for the community overall.
One thing we hear from patients a bit is just how they feel like they've been left behind compared to the hemophilia community, and that's resulted in a little bit of disengagement. I think at times we hear from chapters that, as they're putting together their agendas for family education days and events to educate their members, there's oftentimes super exciting news about new innovations and treatments that have just been approved in hemophilia. But what vWD patient wants to come to yet another meeting that's full of that kind of content and really no updates or excitement for them. And so it's been really fun for us to be able to join some of these meetings, kind of bring updates on our clinical program, talk about the opportunities to participate in research, and hopefully advance the standard of care for those individuals with vWD.
And to that end, again, coming off of the Bleeding Disorders Conference just a couple of weeks ago at the time that we're recording this, I heard from at least a handful of people with vWD that they wish there had been more at BDC for the vWD population. And that's not a new request either. So work to be done on the advocacy side, on the biotech and clinical development side, work to be done all around. But I want to ask one more question. I know we're at the end of our time, Jess, but I want to ask you one more question here. If you had an overarching message to patients and caregivers affected by vWD out there, what would that message be?
Share your experience. Talk about what you're going through. Talk about and record your bleeds and discuss that with your physician. Make sure they know about all of your bleeds. And know that you don't have to continue suffering. I think every time you speak up as a person with vWD, you help other people realize that their situation is probably quite similar. And that's part of why we love learning the stories of people impacted with vWD and highlighting them on our website and helping to raise the voices and the profile of these people's experiences. Because once they realize they can reconnect with their physician, talk about what's really happening, that's the start of the journey of actually getting the care that they deserve. And we look forward to doing our part from a research perspective to continue to bring innovation to that community as well.
And you mentioned the stories on the website. As a fan of stories, I want to underscore there are a couple of great videos on star-therapeutics.com. If you take a look at the VEGA program, VEGA, that's the clinical trial program, you can see a couple of videos that demonstrate the unmet needs within von Willebrand disease. We'll have links to that in the program notes. And I think it would be great, Ben and Jess, maybe 6 months from now, we do this again. We can check in on clinical trial updates, anything particularly notable, some milestone coming up in the future. I'd love to track this for the benefit of keeping people with von Willebrand disease in the loop and letting them know that we at BloodStream are paying attention as well. So let's do this again in say 6 months' time. All right. Well, thanks for your time today. Appreciate you joining me.
Thanks, guys.
Thanks, Patrick.
Thanks again, Jess and Ben, for coming on the BloodStream podcast and sharing with me. Amy does greatly appreciate everything you had to say. She just also appreciates self-care.
I miss it for therapy. Dang it.
Thanks as well to our presenting sponsor, Takeda, bleedingdisorders.com, to learn more. We could not produce this show without your support, and we are grateful for it. All right, Bordeaux, next episode comes out September 26th, our last of the month. And boy, are we barreling toward the end of the year. What can listeners expect to hear on that one?
We have our latest gene therapy segment, which is going to be fantastic. And Jessica Locke, who is a Heme B caretaker and a TikToker, a prolific TikToker. But I think this is fascinating. She does so without sharing her child's name or image.
She advocates.
That's baller.
She's going to tell you how she came to do exactly that baller thing on the next episode of the BloodStream podcast. With that is all for this episode. So you're going to have to subscribe to make sure to have that next one delivered to you the moment it goes live. And with that is all for this episode. Be sure to subscribe to the BloodStream podcast wherever you listen to those podcasts to make sure you get that next one the moment it goes live.
And as always, listeners, you can email us at mailbag@bloodstreammedia.com to inquire about BloodStream Media and Believe Limited, casting opportunities, or to share your story, or maybe get a chance to be on the podcast. We would love that. You can find me and PJL on social media. You can also direct message all of our show's social media at bloodstreammedia.com.
I am your host, Patrick James Lynch.
And I am your other host, Amy Board.
And until next time, take self-care of yourself. Bye, everybody.
Bye-bye.